Imagine a highly pressurized, incredibly fragile water balloon hidden entirely inside a toddler's abdomen.
Oh, wow.
Right. You can't see it. The child might just seem like a little fussy, or maybe their clothes are fitting a bit tighter than usual.
Right, the subtle signs.
Exactly. But as a nurse, if you press on that child's stomach during a routine physical assessment, I mean, one wrong touch, one overly aggressive palpation, and that balloon pops.
It's terrifying.
It really is. In a fraction of a second, you've spilled a deadly systemic crisis throughout the child's body, turning a highly curable localized condition into a catastrophic emergency.
It completely upends the traditional rules of a head-to-toe nursing assessment.
Yeah, for sure.
Usually you're trained to palpate, right? To feel for abnormalities. But here, doing your standard job could literally be fatal.
Welcome to today's deep dive. If you're listening to this, you are a nursing student prepping for your ATI RN Pediatric Nursing Proctored exam.
We know exactly the kind of pressure you're under right now.
Oh, absolutely. And we know how incredibly dense the textbook material on pediatric neoplastic disorders can be.
Especially chapters 39, 40, and 41. It's a lot to take in.
It is. So today, we are shortcutting your studying process. We're pulling the absolute must-know clinical realities about pediatric organ, blood, and bone cancers right from those sources.
Helping you avoid that dreaded information overload?
Exactly. But more importantly, we're going to explain the why behind the symptoms and the treatments.
Because when you understand the physiological mechanics of, well, how these diseases actually operate, you stop memorizing random lists of nursing interventions.
Right. You start predicting what the patient actually needs.
Exactly. The exam questions stop being trick questions and start looking like logical clinical scenarios.
Okay, let's unpack this. We're going to start by looking at what happens when a tumor grows in a fixed physical space, like an abdominal organ.
Moving from the localized stuff to the systemic.
Right. Then we'll explore what happens when the rebellion starts in the very system designed to travel everywhere. I mean, the bloodstream.
The liquid cancers, yeah.
Yep. From there, we'll examine structural cancers in the bone and muscle, and finally, synthesize the universal nursing realities for kids undergoing treatment.
It's a journey, really. Let's look at that water balloon you mentioned earlier.
Oh, the Wilms tumor.
Yeah, that is the classic presentation of a Wilms tumor, which is also known as a nephroblastoma.
It is wild to me how specific a Wilms tumor is in its target demographic.
Right. It's so isolated.
It almost exclusively strikes toddlers, usually, between the ages of 2 and 3. And structurally, it's typically unilateral, meaning it confines itself to just one kidney.
Well, the silver lining of that highly specific presentation is that a Wilms tumor rarely metastasizes early on.
Well, that's good.
Yeah, it stays put, but it grows very aggressively within its original location.
Which brings us back to that cardinal rule of nursing care for this patient. Do not palpate the abdomen.
Ever.
You'll literally see warning signs posted on the child's door, on their chart right above their bed. Just do not touch.
What's fascinating here is the mechanics of why that rule is so uncompromising.
Okay, break that down for us.
A Wilms tumor is encapsulated. It is entirely contained within this very delicate, thin membrane that holds all those malignant cells tightly together.
Like the water balloon skin.
Exactly like the balloon. If you push on the abdomen, the mechanical pressure forces that fragile capsule to rupture.
Oh.
And when it pops, you are essentially seeding the entire abdominal cavity with active cancer cells.
So you've basically just given the cancer a free pass to spread everywhere.
You have. And because of how precarious that capsule is, the medical team doesn't waste any time.
Right. The clinical protocol usually dictates a rapid surgical removal, right? Getting the tumor and the affected kidney out, often within 24 to 48 hours of admission.
Yeah, you get the intact capsule out before it even has a chance to break.
And then follow up with chemo or radiation just to ensure no microscopic cells were left behind.
Now, contrast that encapsulated stay-put nature of a Wilms tumor with the other major abdominal neoplasm you'll see on your exam.
Ah, neuroblastoma.
Right, neuroblastoma.
Neuroblastoma is a completely different beast. While Wilms usually stays localized, neuroblastoma is notoriously known as the silent tumor.
Because it sneaks up on you.
Exactly. In about half of all cases, by the time the child is diagnosed, usually around a median age of 22 months, the cancer has already metastasized.
Right, because it originates in the adrenal gland or the sympathetic chain of the retroperitoneal area.
The nervous system.
Yeah, and because the sympathetic nervous system stretches throughout the entire body, the tumor has a built-in highway for early metastasis.
So if it is already spread by the time the parents bring the child in, what does that actually look like clinically?
There are very specific visual manifestations you absolutely must recognize for the exam.
Like what?
A child will often present with an ill appearance, severe bone pain, and highly distinct facial features.
The eyes, right?
Yes. Periorbital ecchymoses, which look like dark raccoon eyes, and proptosis, which is a visible bulging of the eyeballs.
And those visual cues happen for a very mechanical reason, don't they?
They do. The neuroblastoma frequently metastasizes to the bones of the skull, specifically the orbit right behind the eye.
Oh, wow. So it's pushing from the inside.
Exactly. The growing tumor physically pushes the eyeball forward, causing that bulging proptosis. And the pressure causes localized bleeding into the surrounding tissue, creating those dark, bruise-like rings.
That's horrifying, but so important to visualize for the test. And diagnosing it involves looking for the tumor's chemical footprint.
Right, the catecholamines.
Yeah, because neuroblastoma originates in the adrenal medulla, which is basically the body's adrenaline factory. The tumor secretes excessive amounts of specific byproducts.
As the body attempts to break down that massive excess of fight-or-flight hormones, it creates waste products known as catecholamines.
So you test the urine, right?
Exactly. You diagnose neuroblastoma by testing the child's urine for elevated levels of two specific catecholamines, VMA and HVA.
Got it. So finding those byproducts dumping into the urine is a massive red flag that a neuroblastoma is actively pumping out rogue hormones.
You nailed it.
So we've seen what happens when a tumor sets up a physical home base in the kidneys or the adrenal glands. But what happens when the cancer doesn't have a localized starting point?
This brings us to a disease that is systemic from the very first abnormal cellular division.
Leukemia.
Yes, leukemia. It's a cancer of the bone marrow and the lymphatic system.
And it's the most common childhood cancer, right? Hitting its peak incidence between the ages of 2 and 5.
Correct. You will primarily see it divided into acute lymphoid leukemia, or AAL, and acute myelogenous leukemia, AML.
Okay, I want to pose a logical question here that constantly trips up nursing students.
Go for it.
The literal definition of leukemia is a massive runaway overproduction of white blood cells.
Right.
So if a child has a sky-high white blood cell count, why are they at such a severe risk for infection? I mean, shouldn't that massive army of immune cells make them practically invincible to a common cold?
It is the ultimate paradox of pathophysiology.
Right. It seems backwards.
It really does. But the fundamental issue is that these massively overproduced white blood cells are completely immature. They are called leukemic blasts.
Okay.
Think of them as untrained, defective recruits. They have the uniform, but they have absolutely no idea how to fight an infection.
So they're essentially useless for immunity.
Worse than useless, actually, because they multiply so rapidly that they physically pack the inside of the bone marrow.
And the marrow can't expand.
Exactly. The marrow is a rigid, hollow space inside the bone. It cannot get any bigger. So these defective blasts physically crowd out all the healthy, functioning cells that are trying to develop.
The factory is completely jammed with defective products.
Yes, that's a perfect way to look at it.
And this overcrowding creates a very specific triad of physiological consequences.
It has.
First, the blasts crowd out the red blood cells, causing severe anemia. That explains why the child presents with extreme pallor and fatigue.
Right, consequence number one.
Second, they crowd out the megakaryocytes, the cells responsible for making platelets. This causes thrombocytopenia, leading to petechia, spontaneous bruising, and bleeding.
And the third consequence is that they crowd out the healthy, mature white blood cells, causing profound neutropenia.
Wow.
So despite the lab work showing a massively elevated total white blood cell count, the child has virtually no functional neutrophils. They are completely defenseless.
That mechanism beautifully explains the progression of symptoms. I mean, early on, you see a low-grade fever from the neutropenia, petechiae from the lack of platelets, and an unsteady gait as the marrow becomes packed and painful.
But the late signs show the systemic damage.
Right, hematuria as bleeding worsens, agonizing mouth ulcers, and even increased intracranial pressure as those blast cells start infiltrating the central nervous system.
Confirming this diagnosis requires looking directly inside the jammed factory, which means a bone marrow aspiration.
And as the nurse, you are responsible for the strict positioning guidelines during this painful procedure.
Absolutely. For older children, you assist in positioning them to access the posterior or anterior iliac crest of the
But
pelvis.
for infants, it's different, right?
Yeah, for infants, the tibia is often used because the bone is softer, easier to access, and the leg can be held firmly steady.
Okay, so because leukemia cells are notorious for hiding in the central nervous system,
Mm.
literally crossing the blood-brain barrier, the child will also need a cerebrospinal fluid analysis via a lumbar puncture.
Yes.
And your physical prep here dictates the safety of the procedure. The child must have an entirely empty bladder before you begin.
That's crucial.
Then you position them in a tight side-lying position with their head flexed firmly down and their knees drawn all the way up to their chest.
The biomechanics of that fetal position are vital. Flexing the head and drawing the knees up literally pulls the spine taut and spreads the vertebrae apart.
To give the needle room.
Exactly. It opens up the tiny spaces between the spinal bones, so the provider's needle can safely slip into the subarachnoid space without hitting solid bone or damaging the spinal cord itself.
And what about the empty bladder?
Well, the empty bladder prevents accidental voiding during a highly stressful moment, but it also physically increases the intra-abdominal space.
Ah, so they can curl up tighter?
Precisely. It allows the child to pull their knees up tighter without agonizing pressure on a full bladder.
Post-procedure, the guidelines require the child to remain completely flat in bed for 30 minutes.
Right.
Keeping them flat prevents the cerebrospinal fluid from leaking out of the fresh puncture site, which is, the primary cause of a debilitating, throbbing spinal headache.
Moving from the liquid marrow where the blood is born, we naturally progress to the hard structural bone that surrounds it.
And the soft tissues that attach to it.
Yep. Let's look at Chapter 41.
Let's break down the two major bone cancers, osteosarcoma and Ewing's sarcoma.
These are huge for the exam.
Osteosarcoma usually strikes right during major adolescent growth spurts, around age 15, and it specifically targets the metaphysis, the ends of long bones, most commonly the femur. Ewing's sarcoma, conversely, occurs in the diaphysis, or the central shafts of long bones, and occasionally the trunk bones.
The location changes everything.
It does. And here's where it gets really interesting. I want you to imagine the skeletal system as the structural framework of a massive, load-bearing bridge.
Thinking like a structural engineer clarifies the treatment protocols entirely.
So think of osteosarcoma as a massive, destructive flaw right at the joints and hinges of that growing bridge.
Okay.
Because the cancer is physically destroying the joint, the moving part that bears the entire weight of the structure. You can't just patch it with concrete. The structural integrity is gone.
Right, the hinge is broken.
Exactly. This is why treating osteosarcoma frequently requires the extreme mechanical measure of removing the joint entirely.
Meaning a surgical amputation or a highly complex limb salvage procedure where the bone is replaced with metal prosthetics.
Right. But Ewing's sarcoma, however, is a flaw in the main supporting pillars, the long, straight shafts of the bone.
So you don't have to remove the joint.
Exactly. The treatment protocol for Ewing's focuses on intensive radiation and chemotherapy to eradicate the cancer cells within the pillar, preserving the limb itself. Amputation is generally not the first-line treatment for Ewing's.
That structural distinction dictates the entire nursing care plan. Osteosarcoma equals surgical amputation or salvage. Ewing's equals radiation and chemo.
So for the adolescent facing an amputation for osteosarcoma, your post-op care is intensely focused on neuropathic pain management.
Yes. The provider will likely prescribe amitriptyline, which is a tricyclic antidepressant.
And you must understand why an antidepressant is used here.
Right. We are not prescribing it to treat clinical depression related to the cancer diagnosis.
That's for the nerves.
Exactly. Amitriptyline alters the way nerve signals are processed in the brain, making it highly effective at managing severe neuropathic pain.
Like phantom limb pain.
Yes. It interrupts the misfiring nerve signals that cause phantom limb pain, that agonizing sensation that the amputated leg is still there and actively hurting.
And alongside managing that phantom pain, you are preparing that teenager for a temporary prosthesis almost immediately after the amputation surgery.
Right away.
The physical therapy team doesn't wait months for the stump to heal perfectly. They get the patient fitted and moving right away to preserve joint mobility.
And to immediately begin the psychological adaptation to their altered body image.
Now, before we move off structural cancers, we must discuss rhabdomyosarcoma.
Yes, the soft tissue cancer.
This is the most common soft tissue malignancy in children, originating in undifferentiated mesenchymal cells that are supposed to develop into striated skeletal muscle.
The tricky part about rhabdomyosarcoma for an exam is that the symptoms depend entirely on the location.
Because skeletal muscle is everywhere.
Exactly. It's voluntary muscle. It moves your eyes, it lines your throat, it moves your arms. So this cancer is a total chameleon.
If the tumor begins growing in the muscles of the nasopharynx, the child might present with chronic epistaxis or severe nosebleeds as the mass erodes local blood vessels.
Right. And if it grows in the tiny skeletal muscles behind the eye or within the central nervous system, the child might present with strabismus or sudden double vision.
The symptoms simply mimic the physical disruption of whatever space the tumor is invading.
So we've covered the fixed organs, the circulating blood, and the structural bones and muscles. Now we need to synthesize the systemic realities of pediatric oncology nursing care.
Because regardless of where the cancer originated, the primary medical weapons we use to fight it, chemotherapy and radiation, are effectively blind.
Right. They do not know the difference between a malignant cell and a healthy cell.
They simply target any cell in the body that is rapidly dividing.
If we connect this to the bigger picture, cancer cells divide chaotically and rapidly, which makes them susceptible to these treatments.
But hair follicles, the delicate mucosal cells lining the gastrointestinal tract, and the vital stem cells inside the bone marrow are also naturally rapid dividers.
Unfortunately. And the systemic destruction of these healthy cells creates the universal complications that dictate your entire daily nursing care plan.
The most dangerous of these complications is myelosuppression.
Absolutely.
Myelosuppression is the pharmacological shutting down of the bone marrow factory. As a pediatric oncology nurse, you absolutely must know how to calculate the absolute neutrophil count, or ANC.
You need to assess your patient's true mathematical risk for a lethal infection.
You cannot just glance at the total white blood cell count and assume the child is safe.
The calculation is straightforward, but it's critical. You take the total white blood cell count and multiply it by the percentage of actual functioning neutrophils.
And you find that percentage by adding together the polys or segs with the bands on the lab report.
Right. Let's clarify what those terms mean.
Oh yeah, good idea.
Polys and segs are the mature, fully armed adult neutrophils.
Okay.
Bands are the immature, teenage neutrophils that the suppressed bone marrow has rushed out early in a desperate attempt to help fight off an invasion.
So by adding the adults and the teenagers together, you get the total percentage of cells that can actually mount an immune response.
Exactly. Multiply that percentage by the total WBC, and you have the ANC.
If that ANC drops below a specific threshold, the child is profoundly neutropenic.
And your nursing interventions shift immediately to protective isolation.
The environmental controls become incredibly strict. I mean, no fresh fruits or raw vegetables on their meal tray because the microscopic bacteria naturally living on an apple skin could be lethal.
Absolutely no live vaccines either.
And you will administer filgrastim, a targeted medication that physically stimulates the bone marrow to wake up and produce more white blood cells.
The next major systemic complication of targeting rapidly dividing cells is mucositis.
Oh, that's rough. Severe, agonizing ulcerations of the gastrointestinal tract, most visibly in the mouth.
Because the mucous membranes are some of the fastest replenishing cells in the human body, so chemotherapy absolutely shreds them.
Now, I want to push back on the treatment for mucositis because clinical instinct often leads students down the wrong path here.
Oh yeah, this is a huge trap.
If a pediatric patient has a mouth entirely coated in bleeding, painful sores, wouldn't the easiest solution be to give them a heavy, numbing mouthwash? Or maybe have them swish some hydrogen peroxide to bubble up and chemically clean out the dead tissue?
Following that instinct on an exam will result in a failed question. And in clinical practice, it can severely harm the child.
Wow.
You must actively avoid those traditional medicine cabinet remedies. Viscous lidocaine, that heavy numbing gel, depresses the gag reflex.
Roxy, and a young child who is already nauseous and fatigued, wiping out their gag reflex creates a massive aspiration risk.
They could silently aspirate their own saliva or vomit.
That makes sense.
Exactly. And hydrogen peroxide might bubble nicely on a scraped knee, but inside a chemo-shredded mouth, it aggressively destroys the new, fragile cellular growth the body is desperately trying to form, significantly delaying healing.
What about those classic lemon glycerin swabs you always see in supply closets?
The acid in the lemon literally erodes the already compromised mucosal tissue.
It is the biological equivalent of pouring acid on an open burn.
Exactly.
So what are the correct, safe interventions?
You provide a very soft toothbrush to prevent mechanical bleeding of the gums.
And for rinsing?
You use a non-alcoholic chlorhexidine mouthwash or a very simple, gentle mixture of basic table salt and baking soda dissolved in water.
because it physically cleanses the sores and balances the pH of the mouth without causing further chemical burns.
The final piece of managing myelosuppression involves addressing the other two lines of the bone marrow factory, the drop in platelets and red blood cells, resulting in hemorrhage risk and anemia.
Implementing strict bleeding precautions is a constant background task during your shift.
You avoid any unnecessary skin punctures.
And if you absolutely must perform a needle stick or start an IV, you hold continuous, firm pressure on the site for a full 5 minutes afterward to ensure a clot forms.
And you completely eliminate taking rectal temperatures.
Because the mucosal tissue inside the rectum is incredibly fragile and packed with microscopic blood vessels, right? Right. Inserting a thermometer could cause a tiny tear that, in a severely thrombocytopenic child, results in unstoppable hemorrhaging.
To actively manage the bleeding risk, you'll frequently administer transfusions of packed red blood cells and platelets.
Alternatively, the provider may prescribe oprelvecin.
That's a hematopoietic agent that directly stimulates the bone marrow to increase platelet production, right?
Exactly. It is a constant, delicate, balanced act of protecting the child from environmental threats while simultaneously trying to kickstart their internal cellular factories.
So what does this all mean? We have navigated the terrifying, do-not-touch physical fragility of an encapsulated Wilms tumor.
Right.
We unpacked the paradoxical systemic overcrowding of the marrow in leukemia, where an abundance of white blood cells actually leaves a child defenseless.
We explored the structural destruction of osteosarcoma at the hinges of our skeletal bridge versus Ewing sarcoma in the pillars.
And finally, we synthesized the intense, proactive nursing care required to protect a child from the devastating collateral damage of chemotherapy and radiation.
This brings me to a final thought I want you to consider before you close your textbook today.
Okay, let's hear it.
We spend so much of our clinical energy focusing on how to eradicate the cancer, the math of the ANC, the protocols of isolation, the surgical precision of an amputation.
Right.
But consider the holistic reality of survivorship. Think about the profound cognitive late effects of pouring a highly neurotoxic chemotherapy into the bloodstream of a toddler whose frontal lobe is still actively developing.
Oh, wow.
We frequently cure the cancer, but at the cost of long-term chemo brain, leaving the child with permanent deficits in executive function, memory, and learning.
Or think about the overwhelming psychological weight of survivorship guilt.
Yes.
Imagine an adolescent who finally enters remission, only to realize that their friend they met in the next hospital bed did not survive. As a pediatric oncology nurse, you are never just treating a tumor on a scan.
You are managing the immediate physical crisis, yes, but you are also the bridge to a future that the child now has to completely relearn how to navigate.
The interventions you provide today shape the adult they will eventually become.
That is the true weight of the job. You aren't just memorizing guidelines, you are safeguarding an entire life trajectory.
We hope this deep dive has clarified the physiological mechanics of pediatric neoplastic disorders for you. Best of luck on your ATI RN Pediatric Nursing Proctored exam. Trust your knowledge, think about the why behind the symptoms, and we will see you on the next deep dive.